Good evening. I have the honor on behalf of UNICEF to just have a brief opening remarks. And I mostly wanted to just say what a privilege it is for UNICEF to join this I3 Summit, really because of the opportunity to learn, listen, and work more and more with experts, innovators, academics who know media, who know data, and genuinely how do we push forward quickly on progress. I wanted to pick up on Sandeep's fireside chat last night, which I think was extremely useful in terms of framing what we're trying to do here together. And as we at UNICEF are looking at this, and as I looked at this august panel and looked at the participants yesterday and over the next 2 days, it's really how we're looking at strengthening that public health system, looking at the innovations that genuinely enable us to make sure that public primary health care are accessible, quality, far-reaching, and able to close that last mile gap. One of the things that really pressed on UNICEF from the opening last night was how do we converge to accelerate change and bring the innovations, leverage technology for things like telemedicine. How do you bring electronic health records together so that people are able to move around and have access? For children, this is particularly important. How do you look at improving data and making sure that you are able to have good data, but also timeliness in provision of services? And one of the things that BFI has pushed us in our partnership with UNICEF is really looking at designing resilient health systems that we learned during COVID. The importance of being able to have a health system that can withstand those shocks, whether it's from a pandemic and a health crisis or funding crisis that we see in many countries. And that's why we're here. And I think last night, Sandeep reminded us that as we look forward, how do we look at these countries that are lower or middle income countries that often have gaps in the healthcare system because of funding gaps or lack in data that is accessible and speedy. And that's why we're pleased to be here. And as I thought about framing this from UNICEF's perspective and I looked at this panel, I wanted to be inspired by the 3 I's and talk about the 3 P's. And the first is partnership. And UNICEF, an open secret is that we don't do anything alone. We work around the world with governments. We work with the government of India so that when we try something and it works, the government has systems to take it to scale. And when it doesn't work, we can recalibrate. We work with civil society and non-government organizations, and we'll hear from them because they're on the front line. They know communities, they're trusted by communities. We work with academics and the private sector to make sure that we're going and growing as fast as we can. We partner in order to make sure that we can really push our purpose. And I think Sandeep last night really pushed us on everybody has a purpose and a role to play. And this is where we're able to look at those weaker systems and make sure that we strengthen them. And one of UNICEF's purposes is looking at tangible, measurable goals. The Sustainable Development Goals, they're behind. SDG 3 is not where it needs to be. And so working with partnerships to achieve that purpose of moving forward to reach goals and really looking at how do we take what is new, like innovations or technology, and accelerate them. So I've had the opportunity to visit Gujarat, where there's a powerful accelerator through technology in the Narmada district, working with technology, health centers, primary healthcare centers, closer to communities, closer to children, are screening for the 4 Ds, defects, diseases, delayed learning, and deficiencies. And that enables a family, a mother, to know closer to her home what she may need to intervene sooner. And that's all because of technology, closer to the family home, closer to the community. We partner for purpose in order to reach real people. And I think that's what's exciting about this panel, is that you're talking to real people and making change that really impacts lives. And this is where I would highlight India having the largest frontline health worker force, 2.5 million frontline workers who are in the communities reaching out and able to share with mothers, with families, with communities, and identify children early on and the needs they have. It really makes a difference to have them on the front line, but there's more that we can do to make it stronger. So in Rajasthan, for example, just a few years ago, frontline worker Mamta, she'd walk 3 kilometers a day, but also carrying a weight of paper of about 6 kgs of the forms that she had to fill out. But thanks to the partnership between the government and UNICEF, Anmol was created. So now Rajasthan's frontline workers have a single data app that enables them to input data, get regular updates, and also then free up time and efficiencies in order to be able to manage her 350 families that she's trying to manage. So with that, I would say, as I looked at this and the 3 I's and the 3 P's, and as I looked at this panel, that this is an exciting summit and panel because we're partnering with purpose to reach real people. So thank you for that.
Thanks, Cynthia. At this evening, I have a couple of requests. One is I request you all to engage with the panel. So all of those of you who've chosen to be here, if you could just move forward. And whoever is closest to the door, please close the door if possible, because there seems to be some noise. So maybe you want to just get up and walk a few steps. It's not a lot of exercise to ask for. Please come. I'm going to wait for you till you walk up here so we can actually have a conversation. The better part of 2 decades of my career has really been about making unheard and invisible communities' voices be seen and heard and articulated in a way that health systems can actually remove their blinders and remove their earmuffs so they can see those vulnerable communities and be responsive. And responsive is another English word in our massive lexicon of jargon that we throw around, equity and catalytic finance and God knows how many conferences we all have been, jointly and separately. Where have you experienced the lack of responsiveness? In very specific, like a very specific story, if you can think about it. And I'll come back to you on the contra a little later, if you may.
Thank you. I first of all agree with all the 3 responses, and there are many more. I will just start with the recent health and wellness centers that were set up. What really happened was the same place was painted and baptized and a name given. But in the entire process, the women, I'm only going to talk about women because I represent the informal women workers in India. The women were not part of it at all. So they did not understand what the change is. They did not understand what's new there. It was just the name, and there was some symbol and something new happening there. So what we experienced, because I've been working for 40 years, I'll say 40 years back, we have the same problem even today. Women do not know what's happening. They do not understand the health system. They have no clue. Awareness is not there. Health education is not there. Health literacy is still not there. So there is a disconnect there with the community. So that to me is the most important, like somebody said here, that it has to be a ground-up approach. When you start painting and designing and creating, it has to be with the people, with the community, with the women. So I totally agree with what Cynthia said. I would say the P stands for people-centric, participatory, and partnership.
Thanks, Susan. Nandita, I'm sure you've had experiences where louder. Oh, maybe it's quite loud here. I'm sure you've had experiences where your personal experience was not necessarily people-centered or human-centered or even you-centered or your needs-centered. or you have. So give us a good or a bad story from your perspective, and maybe share a bit about your perspective. It's your story to tell on when you have accessed the health system and when you faced such a challenge or a silver lining. A challenge, a challenge or your silver lining in your experience with the healthcare system. Choice is yours.
Thank you. Thanks a lot. So let me start my by starting with a story of a very young girl. She was aged 17, and she was a bright young girl with a lot of dreams, with a lot of ambitions. She was a very ambitious girl, a college-going girl, who suddenly got to know one fine day that she had contracted this disease that was called as tuberculosis. She hadn't even heard about this disease ever. No one she knew about in her family, in her extended family, ever even heard of this disease named TB. And people around her told her that this is a disease that usually people who are extremely poor or people who have very limited means, they are the ones who contract this disease. How did you end up contracting this disease? So this young girl got this disease called TB when she was in college. And then finally, when she got cured, she moved on with her life again. And again, 4 years after that, the disease came back into her life once again. And this time, the disease was way more dangerous, the disease was way more serious, and the disease was at the end stage in her life, wherein the disease was termed as life-threatening for her. She had to end up undergoing nearly 6 surgeries in her abdomen, which is where she had contracted the TB. She was hospitalized for nearly 3 months, precisely 90 days in a hospital. She was scooped away in a room for 3 months. And then all of a sudden, one fine day, she gets to know that she has lost her hearing, both hearing on both her sides, bilateral hearing gone, with one fine snap of a finger. Overnight, she lost her hearing. Why? Well, because it was because of a TB medicine that was administered to her as part of her treatment. But well, that came as the biggest blow to her when she was all of just 24 years. Can any of you imagine at the age of 24, a young girl, suddenly her life turns upside down with staring at a life-altering hearing loss? A girl with full of dreams, suddenly her life has been trampled upon. And then, even with all of that, she finally decides that she has to move ahead in life. And years later, she decides to tell her story at the United Nations in front of all of the heads of states and health ministers in New York. And this was in 2018. And well, this girl is none other than me, sitting over here. And this is my story with TB. This is what had happened to me. I was just 17 years. And then, yes, this was my story when I got a chance to speak at the UN with the health minister, JP Nadda. I addressed a bunch of health ministers at the UN General Assembly in 2018. Well, it was not a simple journey. It was anything but, if I have to say, patient-centric or person-centric and all the wonderful terms that we often use in a lot of panels and conferences. But yes, it was a difficult journey for her, but she decided that she will not let this journey end her life. She will turn that pain into power, and she is going to go ahead and speak up and point out what needs to be done, what are the systemic flaws that need to be addressed. So according to me, I feel that there are some points that I would like to raise, starting with a very important point that I want to bring in. I want to merge two of my favorite concepts, a concept in economics called rationality, that is called as rational choice, where a consumer is often said that he or she often opts for a rational choice when he has to take a decision. And I'm going to bring in the other entity here, and that is a patient. Often what happens is that I've often seen that the health system often assumes somehow that the patient is always undergoing irrational behavior. The patient is often felt that whenever we speak in terms of a patient, whenever we want to speak about patient care, the immediate response is that, oh, the patient is maybe not interested in getting cured. Or the patient is dropping out of treatment because maybe she doesn't want, maybe he's not interested about her health after all. Maybe she does not want to, maybe she is just not interested in getting better. Maybe she has just given up on her life. But have you ever realized that it is actually the reverse? I must tell you that a patient is actually making the most rational choice, but not in the way that everyone thinks about. And I'll explain to you how. When a person who is especially fallen sick, a person is always and constantly weighing what we think as the opportunity cost. A person, when he has to take a medicine and he knows that the medicine is going to cause immense side effects, a medicine that is going to stop his life every day, he knows that taking the medicine is going to come at the cost of losing probably a day's pay, or probably losing a day of wage, probably not being able to go to work, not being able to go to school, or not being able to go to college. The person is actually making what she feels or he feels is a rational choice, that I don't want to take this medicine. I don't know whether this is going to make me better. No one has told me it is going to make me better after all. But I will want to, after all, go and earn my money. I don't want to lose out on my pay. So I often feel that the health system, there is an approach in the health system that I feel fundamentally tends to the fact that, okay, a patient is maybe not very interested in caring about himself, in caring about herself, but is actually the exact reverse. A patient is constantly weighing the opportunity cost of doing one thing versus foregoing something else. And it is up to us and everyone seated here to be able to ease that pathway at every step by improving, say, for example, by improving the immediate diagnosis. It gets done quickly by having better medications in place, by having better post-operative and post-treatment care in place, so that the cost of making the cost of making the choice gets as simple as possible for everyone and anyone who's dealing with the disease.
Thanks, Nandita. And that's a really good segue to going to you, Neeraj, because you work with technologies that make things accessible, timely, feedback loop very quickly to the patient. So maybe share with us some of the challenges in the environment, because your objective is to make diagnostics and tools exactly that. And what are the challenges in the environment that you're currently dealing with, and maybe a success story or two?
Sure. Thank you. Is this working? Yeah, it's working. Yeah, okay. Firstly, thank you, Angela. The biggest challenge I have tonight is that my entire script has gone out because Angela changed the questions. So thank you for that, as expected. But
Makes for a more interesting conversation, no?
absolutely, absolutely. But I think, I've got a problem with the word responsive. I think it's a very colonial term. I don't think, I think it's a top-down kind of a thought process. And I think, firstly, we need to turn that around. We can't be looking at a responsive health system. It has to be designed based on the patient. And that's where we need to start. We keep saying we need to design with the patient. Actually, it needs to be designed by the patient, by the frontline worker. And what we've realized more and more is, and as I was walking around and looking at all these innovations, as we walk around, India, there's a lot of innovation happening. A lot of bright, shiny objects, a lot of great ideas, but they are not actually even attuned to the system, the health system, the patient. What does the patient need? Are we actually starting from there? And unfortunately, we're not. One is the patient side of it. And Nandita, of course, I've known her for many years and I've seen her journey. But what about the frontline workers? What about our medical, providers? Are we designing with them? Are they helping us to design? Are they designing some of it? So we actually came up with this Living Labs concept where we started designing in partnership. But even there, we design for a TB diagnostic, but the person walks in with fever, right? Could be TB, could be malaria, could be dengue, could be anything. So are we actually thinking about that? No, we've got a great TB screening tool which we are going to roll out in
You
the
have
health
the
system.
hammer, you're looking for the nail.
Yeah, absolutely. So you've got this lovely TB tool, but person has fever. What are you going to do? What happens when a child is hemorrhaging with acute encephalitis in Gorakhpur? What's the reason? What are we going to do about it? So there are a lot of challenges that we face, and technology, unfortunately, is very close to the innovator's heart. This is my thing. I have had innovators who are ready to hit us. Because we come in and we say, this is not going to work in the health system. But they don't want to hear that. And then they'll say, okay, forget these guys. They don't know anything. Let's go find somebody else, another incubator, Dipanvita. They'll come to you. They'll go to Venture Center. They'll go to C Camp. But and nothing wrong with that because it's very close to their heart. But the health system, I think that piece is missing. The provider, what are they doing? What are the current algorithms in the health system? How does it work? How do patients move from self-care to primary care to district level to tertiary? How do patients move when they come back? What happens? I think those are the important pieces, and I think we miss them in technology completely. We are looking at technology as a bright, shiny object, and I think we need to stop doing that.
Thanks, Neeraj. And the good news is there are still some innovators left in this room. So I really hope that they were paying attention to you and they will reach out to you at dinner time. Yeah. Johnson, you and I have shared stage many, many times. Big admirer of your work with the tribal community. So if you could share in short what you're doing with the tribal community and maybe a story where, because I know you have a lot of stories, maybe a story where the system was not responsive and how you supported the community and the health systems in being, let's say, empathetic towards each other and serving each other's goals. Because I'm taking from what Neeraj said, he doesn't like the word responsive, so I'm finding a workaround to the jargon that actually means they are partners in this well-being journey. Did I get that right? Awesome.
Thank you, Angela, and thank you, BFI, for having me here. With respect to one example, which is alive, which I have seen from my own naked eyes, I come from Jharkhand, and it's around 35 kilometers away from state capital Ranchi. I happen to be, during the monsoon season, happen to travel to the district due to some project works and field visits. I found a village after a 1 hour walk to a village very remote, a village inhabited by the primitive vulnerable tribal communities from Asur community. Asur, they have a population of around not more than 15,000 in the world. So that's the level. And I found when I entered to the village after a walk over 1 hour, because you don't have a road to reach that place. And I found that villagers are gathered in one family, one house. Then I inquired what happened. Then I was told that a day before, a woman at the very early 20s died because of childbirth and heavy blood. It was complete silence why this happened. And the health and wellness center is something like 25 kilometers away from there. No internet connectivity. I'm talking about in the year 2016. And why you did not approach? Because of the lack of internet, lack of telephone. This community completely excluded forested villages, really far off from the mainstream of development. No electricity, no interconnectedness. And I found that, and they tried to reach to a quack, a traditional healer. And a person, her husband actually walked almost 14 kilometers away to get him for the treatment. And by the time he could reach, a wife died already. And why you did not approach the doctor and so on to the health and wellness center? He said that वहाँ जाने से हमें क्या मिलेगा? वहाँ तो हमें गालियाँ मिलेंगी, पेपर पूछेंगे, कार्ड पूछेंगे. कम से कम हमारे घर में मेरे पड़ोसी हैं, हस्बैंड है और बाकी सारे साथी लोग हैं जो कम से कम there is a solidarity to share that struggle. And that has been the experiences. So just coming back to your question, is that how responsive is this? I heard that the Health and Wellness Center was opened 6 months ago from that incident, and it's not responsive. The way these communities are being treated is that they don't feel like going there. There is no empathy, there is a discrimination, and the person, doctors, they are not very sensitive. The ASHA workers doesn't frequent because at ASHA worker has to really cover large geography in order to reach there. And it's a forested, undulating terrain, and at those points of time, those geographies were bordering Chhattisgarh, and then we had a Naxal movement also running. And the army forces, paramilitary forces, it was very difficult to really reach out to that community. And we realized that this is how the health system runs. There is no trust, there is no relationship, there is an exclusion, feeling of exclusion, there is discrimination. They really feel afraid of reaching to the doctors, the paramedics teams and so on. Very low esteem, because in Jharkhand, if you look at, I come from that state, almost 40% plus are very marginalized and vulnerable communities. What we did, how do we address this? Because the area that where we are working, FIA Foundation partnering Hope into Action, is that we should strengthen the Panchayat and Gram Sabhas. We found that this is something very, very important aspects which we need to strengthen. And this is a constitutional enshrined institutions, but government has never invested time and energy to really capacitate these village councils. It had 8 standing committees, but dysfunctional. We call it, we used to really make institutions vibrant, and we used to say that na Lok Sabha, na Vidhan Sabha, sabse bada Gram Sabha. This is the kind of slogan to make them recognize that this is a direct democracy, wherein you really define your development agenda. And it took us almost a year to really make them realize that Gram Sabha is something very, very stronger, vibrant institution wherein you make systems accountable and ask that if ASHA worker is not coming, you should ask why they are not coming. If ANM is not coming, why they are not coming. Doctors is not visiting, why they are not coming. And we made it, it took us almost a year time to make this realization, if we are poor, if we are excluded, because there are certain duty that Constitution gives us, which we are not exercising. And after 1 year, we realized and we felt that these Anganwadi workers, health workers, they used to attend Gram Sabha meetings, and scorecards were being asked. What has been the result in the last 1 month? Asking how many testing have happened, how many growth monitoring were done, how much children are coming to the midday meal and so on. So all these service providers used to be participating in Gram Sabha meetings, and we felt that's the only way to really make the service providers more accountable and responsive. And today we see that roads have been built because of this Gram Sabha being active. We saw electricity coming up, ASHA worker visiting, we call it Sahiya, and they're able to really make Gram Sabha as an institution and institution interacting to the institution. We felt that something different has happened. Thank you.
Thank you. So, three big points. Strengthening of local leadership, which includes their capacity building, perspectives, and agenda. And the second one that you spoke about was really trust. Trust and empathy. I'll put the 2 and 3 together, which you also alluded to in terms of trust and empathy. So, which you started with to begin with. So, question for you folks in the room. How many of you here are researchers? Okay. And does trust and empathy show up as a major motivating or challenging factor in accessing studies? Yes. Okay. Any perspective you would like to add or a contra to what you've heard from the panel?
Yeah. Hi, I'm Kalayarasi. I'm the founder of Tramer Private Limited, where we are developing a home test kit, affordable, which can help to detect the early signs of PCOS and PCOD. And as a researcher, I have been in the research field for past 8 years. So I feel that empathy and then carrying towards or being in that position with patients or any other people helps me to build the any kind of policies or even the instruments or devices better way, I would say. So when we consider about inclusiveness as well as patient-centric, but we also consider about the family around the people or the person suffering, so that not only the patient-centric, but also the inclusiveness around the family as well as the community would get better results.
Thanks. That's a good addition, not just the patients, but also the caregivers and the community,
Okay.
adding that. Any other additional perspectives? Yes, please.
Yeah, hi. I'm Sanjay Hazarika from the Center for Northeast Studies. My intervention is going to be very simple because I respond very well to what Mr. Neeraj Jain spoke about, the design of the health system. Because I've designed the intervention I talked about very briefly about the boat clinics. It was basically, we really sweated blood when we went on those islands, to map the problem because the map was complete, the situation, complete lack of access. So when you travel to islands, you can't travel by road or helicopter or even bridge because there are no roads or bridges. You go by boat. And then you map the communities. You start with the most vulnerable communities. Till then, because of the floods, the only time they would see a doctor was during the floods, maybe once or twice, and maybe once in the relief camp. So the design was to develop a program that would bring them into the health system. There was no system. So we did this without the government, without any funding. We just had local support and we went out and did this. And in the process, we created a subsystem within the larger ecosystem that is now part of the government system. Because people trusted us and people needed that system. So that's essentially how it works. It doesn't work because you've designed it in a lab. It works because you go to the people and find out what their needs are. And that's what I say to all the scientists and others here, is that you can have the best things in the world, but unless it reaches the most vulnerable, it's not really effective.
Thank you, sir. I'm going to take this opportunity because I have the mic. I know that BFI is investing in the district stack programs where you're actually trying to find out what really is the problem is from a person's perspective. So I'm going to call on Naga to share what you're trying to do to make the system more responsive than it actually is, and what are the challenges. So I think we learn a lot more from challenges than successes. Do share your successes, you got the mic, but also share some of the challenges and the road forward.
Yeah, I think one thing you can count on Angela is to just put you on the spot. I was not supposed to be on this panel, but yeah, I think a lot of the discussions that we're having here, especially why CNS and FIA are partners to the District Full Stack program is because of the points that the both of them just spoke about. I think the large part of where do we start building solutions starts from really, I think, understanding from the people experiencing the problem and how do they view the problem. And if we are able to get that well and bring that in a way to the design table, whether it's researchers designing a solution or innovators or what's happening in academia, if you're able to make that a two-way conversation to there is lived experience and lived expertise of people experiencing a problem, trying to solve it in their own way. And then if you're able to bring that to the problem design table, start solutioning from that perspective, we believe that we'll be able to move closer to solutions that work for people, that works for the system. Maybe one of the examples that I can give is, don't know if Huda from Selco is here, but one of the insights that we had earlier on working in Meghalaya was you have A&Ms who have living quarters in sub-centers where most of the women would go for deliveries. But because of lack of electricity at the sub-center, the A&M would live at the closest place available, which is maybe 30 to 40 minutes away. And in a lot of cases, what would happen is a high-risk pregnant mother would reach the center, and then it would take 30, 40 minutes for the A&M to reach there, and within that time, the golden period has passed. In cases where, okay, the delivery happens, the health center doesn't have the systems to run the baby warmers, there is maybe to sterilize the equipment, the autoclave is not working, vaccines are not being stored, and so on. So once we understood these aspects of why things were not working at the centers, when we had a conversation with Selco and designed a solution towards solar powering of the health centers and a set of energy efficient equipments to make all this possible. And with the first 100 centers that we did in Meghalaya, solution from there on. And now today it's at a scale where it's been able to create full policy change. So I think that's, in a way, the thought process that there is a pipeline to go from policy to solution and then evidence and eventually integration, not start from policy, no. Problem to solution design to evidence and then incrementally scale until it reaches policy. So. And thanks for putting me on the spot.
You're very welcome. I'm going to come back to the panelists with some very specific asks. Yes, I'm looking at you, Neeraj, but you can take the time to think about it. This is a room full of, there's innovators, researchers, philanthropists, financiers. And this is for all of you, so take the time to think about it. What is your message and from whom that they haven't heard before? Or you need to reiterate in a strong way. I'm sorry, I have to be louder. What is your message for whom? So be very specific, because we say very broad things on panel, but we want something to stick for the folks who are in here listening to us so that they can take it back to them. So what is your message and from whom, so that we can have an empathetic, a trusting partner in our well-being journey? You can start, yeah.
I mean, I can't, the clock is ticking, I can't think, so I'll just go ahead and say what I have to. So for me, the message is for the financiers. All those people who are putting money into innovations for health systems. I think it's very, very important for you to think about the life journey rather than a bright, shiny object. Unfortunately, a lot of things are getting funded, I've had innovators actually say, I got funded, but it's not managed to get into the health system. So the system, it has to start from there and have a very clear vision of how it's going to get incorporated into the system. So don't finance, because what happens is then you're just taking the innovator up the garden path for a while, and then they realize that they're not really getting anywhere. Because unless they hit the health system, unless they're able to actually become commercially viable, they're actually just getting pushed ahead a few times. So be careful how you're investing. Definitely invest. We need a lot more money out there, but be very, very careful. Have a very clear plan of how this is going to scale up. And scale up, I like the district conversation that Naga was just having. For me, in India, if you're not able to do an entire district, saturation, it doesn't exist. Okay, let's not talk about a few villages. It has to hit the entire district. That is your level of governance. I think, Cynthia, you would agree with me. I think UNICEF has a sort of similar thought process. So that should be. But yeah, please don't be very careful how the financing happens.
Thanks, Neeraj.
So my message from the way we work,
Can you hold the mic a little closer? Yeah.
health is not like a, just a stand-alone thing. There are multiple factors that, again, coming back to women, that affect her life. So whenever we are designing something, you have to keep the woman in the center and look at all the problems that affect her, and that, affects her health finally. So we cannot just say, for example, you are finding something for maternal health, all the other things are not important. Everything is important, so you have to look at it and then integrated. Here, integration doesn't mean partnership. What I'm saying, integrated model where you're looking at livelihood, you're looking at financial security, you're looking at food security, social security, everything. How do you solve that? And the problem, like earlier, I want to echo the same thing that was said, that review of literature doesn't review the problem.
Yeah.
You just have to go to the ground, sit down there. I tell most of the young public health students who come to us, I keep telling them for 6 months, don't open your mouth, just listen. You learn and unlearn a lot. And after 6 months, start working. You really come up, you understand that very well. So I think that's very important, and the problem solution also they have. Recently we tried bringing in some technology, blockchain technology, developed an app for, through our frontline workers. And the entire process, there might have been at least 10 or 12 meetings with the people from the tech company, our grassroots workers, and our entire team. And I remember one of the first meetings when the app was put up on the screen, in a matter of 1 hour, half of the things they said, we don't want this. Yeah. And they replaced it with better solutions. Yeah. And they know it. They know better than us. They know what, because they all use the phones. They understand what is it that we can do better. So that should be the way to go if you want to find solutions for the vulnerable, for the marginalized. They are the majority in this country. They are the ones who are going to use, they have to benefit. Yeah. So how do we develop that? And we have to come together and partnership. I saw one of the slides where we said funders, financiers, funders, technology, NGOs, government, all these people have to come together, be on the same page. Then only we'll find solutions. I think I'll stop here.
Thanks, Susan. But your story reminded me of another story back when we were working with blockchain. At that time, we were called Crypto Relief, and we were doing the Vax Now program, 14 million vaccinations for people who had never seen a doctor or even health system. And what we were finding is that the percentage of women who were getting vaccinated was actually 2%. 2% in some of the villages. So we went there and said, hey, what's really happening there? Turns out that the men were coming in because their employers were telling them that you can't work unless you have a COVID certification. And the kids were home. They were not in school. So who's going to take care of the kids and of the elderly? And some of them even serve as security guard at home. They have to just be at home. And so they were not showing up. In one particular place, slums in Mumbai and Bangalore, we actually called pediatricians and GP doctors and said, hey, you know what? We have a child doctor here. So I think you might want to come along with your children, and we have a little playground here, and we sweetened the deal with some food packets, biryani in some places, and the women showed up in droves because they knew that they would have because their motivation at that time was, for many, they didn't have food supplies because a lot of them were daily wages and they couldn't earn, and they needed to take care of their kids for a few hours. Those were the two things. we just took care of those two simple things, and they showed up in numbers we couldn't count. So it's really as simple as that, not so complex. Right. Johnson.
Yeah, thank you. So I think, which Susan has already mentioned, but I also echo the same thing in terms of, if you remember the pandemic crisis that we have all undergone, and we keep repeating those memories, and we have seen how we collaborated to come out. Everybody contributed to that story. And we really fought back those struggles. We have seen in the first half, we were discussing about incubators, biomedical sciences, and everything. But perhaps we are not talking to each other, which I feel. And therefore, I believe that whatever solutions that we are talking about, whatever technology that we are talking about, it has to be closer to the community. And we are the one, we are taking side to the community voice, and we feel that I think they are in isolation in terms of finding solutions. Communities down there are very resilient. They are living with a basic infrastructure and basic livelihood opportunities that they have. Still, they are thriving on whatever they have. But I believe that they should be part and parcel of the entire design process, the solutioning process. And I believe some of our colleagues are working and trying to experiment around human-centric design, when we are really going to understand what are the aspiration and community needs in terms of the health requirement. Have we ever consulted? Most of the time we find that the investment that we make, it is all prescriptive. Somebody has done it, and this is, if this is the problem, this is the solution you have. So it becomes an alien in terms of the community adopting to those technology or the solution. So we are working on those lines in terms of making communitization of those processes and become part of the complete design set, so that we are able to understand, because India is a large country with diverse cultural, socio-economic conditions and ethnicity. And therefore, the one solution cannot be blanket solution for the entire country. Different geography, different solutions we need to think about, and therefore maybe the scientists that we heard have to really interact and think about solutioning from the context in which you are making for the community.
Thanks, Johnson.
I think 3 quick points. First one is that when we are designing an intervention, it is important that we put ourselves in that person's shoes, the recipient's shoes, to actually understand whether we are going in the right track. So I think this applies for every kind of intervention, whoever is the target population that we are looking or intending to benefit. First and foremost, we have to put ourselves in their shoes and understand whether our designing process, understand whether our policy making process is really on the right track. The best way forward is to really get into the other person's mind and think from their point of view, and see whether the solution that we are working on will really apply to them in the way that they want it to. So I think that's the first one. Second one is definitely about putting your money where your mouth is. There's a lot of, I'm aware that there's a lot of funding crisis right now that the general global health situation is facing, not just in India, but globally. So I think this is really the time for India, and also the time for a lot of global south countries to really step up and increase the pedal on healthcare funding in different areas, whether it is in non-communicable diseases, whether it is in communicable diseases, especially in designing, in R&D. So I think we see that there has been a lot of donor-led, especially from the global north donor-led intervention, or excess reliance that we are seeing is starting to backfire. So I think it is important that global south countries begin to get independent when it comes to healthcare funding. So I think it's important. I can see that steps are being made. So it's all in the right direction. So hopefully we should continue on that. And third point for me, which I missed mentioning actually in the first question, is about looking at health from a gendered lens. It is very important that we prioritize women's health in every aspect that we are looking into. Every disease affects, I believe, every disease or every issue in the healthcare system affects women in a very different way, because it is often influenced by the socio-economic setup we are in. So it is very important that we start looking at health, whether it is from the data perspective, to get more robust data, for instance, about women's health in place, to get more robust data about how women are reacting to healthcare systems, to how it is impacting them. So really, I feel that we need more interventions, we need more discussions around women and their interaction with the health system.
Thanks, Nandita. And yes, over to you, Cynthia. I wasn't going to let you go.
All right, 3 minutes over. I think I would pick up on your point that Susan and Johnson also said, communication. We always talk about communicating and how important it is, but the most important part of communicating is listening and hearing. The second is, and especially for the donors, the financiers, and even the innovators, go far. And this picks up on Niraj's point. Go to the last mile. We talk about the last mile, but if you reach the hardest, most vulnerable person on earth is a child who is not well, who may be a minority, who you might not see or might not be able to reach. Go there. Reach that person, and it pulls the whole system. And that means that you can go to scale. But the most expensive thing to do is to reach that child that might be invisible and might not be able to stand up and speak for herself. Go there. And then I think the third point is that pulls you to scale. Go fast. Sandeep said this yesterday, and this is where Susan talks about women and trying to support their families. Children don't have a lot of time. Think about your life. Think about your children. Wasn't it just yesterday that they were little, that you were a child? It goes like that. So we don't have a lot of time. So also for all of us is we have to go fast, but we have to go with listening, and we have to go with what looks like it's the hardest thing, because if we get there, it pulls the whole system.
Thank you. Thank you to, yes, absolutely.
I recently heard it's not mine. Somebody said, it's not the last mile, that's the first mile.
You took my words away. So it's no, that's excellent. But before I thank you all, and thank you all, I actually have an ask. BFI put together such a wonderful conference, not for us to just talk, and some of you here and some of you on the phone. We're going to use this platform as a very specific ask. You have a very powerful platform. You have 100 MOUs lined up with innovators, researchers, collaborative financiers, and people who represent the first mile, people who represent the first mile. So think about how you move forward, how you enable the innovators to open their eyes and take community along with empathy and listening and kindness, and how we might get those solutions to the very first mile, because if we don't solve for all, we actually solve for none. We actually solve for none. So thank you very much to the audience first for staying in the evening and listening to us, and deep appreciation for the panelists for bearing your heart. Thank you.
So thank you to the panelists for this panel discussion, thanking them for sharing their experiences, their concept and approach towards making healthcare more responsive and responsible. And I invite Dr. Shantanu Pathak, the co-founder of Doto Health. Please join us here on the stage as we present Pitomimi. This is an indigenously developed healthcare device, and presenting it to our panelists. This is a pregnancy monitor that is well suited to resource-constrained locations. It is fitting to be presenting it to our panelists here. who in fact are public health champions. Thanking them once again. And would like to also invite here on the stage Mr. Ravi Bhogu, the founder of Monitra, to kindly join us here in presenting his innovation to requesting Dr. Gaurav also to please join. This is to be presented to our moderator. Thank you. A portable electrocardiogram, upbeat by Monitra Health. It records the electrical activity of the heart continuously over 24 hours or longer.